Alaikum class. I hope you are doing fine. So today our topic is about uh, anemia and its type. In the previous lecture, we studied about the folate deficiency, its effects, how vitamin B12 and B9 are differentiated with one another, and their respective effects. Then we talked about an important topic, which is the hemolytic anemias. We talked about how hemolytic anemias are either hereditary or acquired. In hereditary, I told you that they can be classified as cell membrane types, hemoglobin, or some metabolic type uh, deficiency which has altered the normal mechanism and leading to anemia. So we talked about the first two types, the cell membrane type, hemoglobin type. Among them, we talked about different types, its subtypes. Of that, the important ones were thalassemia, in which I told you alpha and beta thalassemia. Then I briefly talked about sickle cell anemia. So we will now continue forward with our lecture. Now, class, we will talk about the metabolic uh, red cell disorders. So this is again a type of hemolytic anemia, which can, which is of hereditary type. Now, a number of red cell enzymes deficiencies may produce hemolytic anemia, and the most common of which is glucose 6 phosphate dehydrogenase deficiency. It is also known as G6PD. So, the deficiency of this particular substance leads to metabolic type of RBC disorders. So, let us now talk about this glucose 6 phosphate dehydrogenase. Now, this is basically an enzyme. G6PD is, in short, for short, is a vital enzyme in a special hexose This maintains the glutathione in a reduced state. What is this glutathione? This glutathione protects against oxidant injury in the red cells. G6PD deficiency is a common heterogeneous X-linked trait and is very common in the Middle Eastern type populations. When there is deficiency of the G6PD, there is neonatal jaundice, chronic hemolytic anemias, and acute hemolysis precipitated by the injection of certain types of beans and certain type of drugs like quinine, sulfonamides, quinolones, uh, etc. The diagnosis is by direct measurements of the enzyme levels in the cells. Treatment is usually through avoiding the precipitating factors. If necessary, blood transfusion can also be done. That was all about metabolic type of hemolytic anemias. Next type class is acquired. So hereditary we discussed. Now we will discuss about certain important acquired hemolytic anemias. The first one is autoimmune hemolytic anemia. So about autoimmune hemolytic anemia, this acquired hemolytic anemia is due to immunological destruction of red blood cells mediated by autoantibodies directed against antigens on the patient's red blood cells. So the red blood cells have certain antigens on them. Immune cells, for some reason, directly involve or affect those antigens, resulting in damage or destruction of the red blood cells. This is known as the autoimmune hemolytic anemia. Autoimmune hemolytic anemia is classified according to whether the antibody reacts at body temperature, uh, the warm antibodies, or at lower temperatures or cold. Uh, hence, the term cold antibodies. Immunoglobulin G or the immunoglobulin M antibodies attach to the results that infected red cell. What happens after that? Results in extravascular hemolysis through the sequestration in the spleen or intravascular hemolysis through activation of certain complements. So it can be extravascular or intravascular. Uh, these autoimmune hemolytic anemias are diagnosed on the basis of a certain test known as the Coombs test, which is the basis of a positive direct antiglobin test. This is a test for autoantibodies or complements attached to the surface of the red blood cells. The red blood cells of the patient are reacted with antiserum or monoclonal antibodies prepared against various immunoglobulins or the certain type of complements like C3D, which are present in these anemias. If both of these or either one of those are present on the red cell surfaces, agglutination of the red cells will be detected in that particular RBC, indicating a positive Coombs test and indicating that there may be an autoimmune acquired hemolytic anemia. Now, class, it will be beneficial for you if I talk bit about this or give you a summary of the warm and cold antibodies type. Now remember class, warm is 37 degrees Celsius, the normal room temperature that you see. The cold one is lower than 37. IgG is common in the warm type. IgM is in the cold type. Coombs test is usually positive in both of these cases. Certain diseases have been known to be associated with these warm and cold antibodies. For example, the warm antibodies. There are conditions or diseases like SLE, lymphomas, or certain carcinomas, or even a drug, certain drugs, for example, methyl dopa, have seemed to be associated with these warm antibodies. When talking about cold antibodies, there is certain infection involvement, like mycoplasma, uh, infectious mononucleosis, even lymphomas have been associated with cold antibodies. So this is some interesting comparison between the warm and the cold one. For better understanding or detailed understanding, you can consult your book. So class, we will now talk about the warm autoimmune hemolytic anemias in greater detail. The main features of warm autoimmune hemolytic anemia is that this anemia occurs at all the ages, involves all the sexes, and has a variable clinical picture. For example, there may be mild hemolysis to even life-threatening anemia. It can be primary or secondary as well. Investigation, as I've told you, is by a positive Coombs test. How to manage this patient if this warm antibodies have been returned? The management is through high dose steroids, and the steroid given is methyl prednisolone, which is common drug. or common steroid given in these patients. About 1 milligram per 1 milligram per kilogram daily is usually given. Splenectomy is usually useful in those patients where steroids are not responding. I have told you before class that spleen is the graveyard of the RBCs, especially those RBCs that have a defective function or inefficient function can readily respond with improvement in the symptoms with removal of the spleen. Apart from that, occasionally immunosuppressive drugs like azathioprine or rituximab have seen beneficial effects on these patients as well. So they can also be given. Now about the cold autoimmune type of hemolytic anemias. Like I have told you, the main antibody in these cold types are IgMs. These are the cold agglutinates. They attach to the red cells in the cold peripheral parts of the body, causing agglutination and finally intravascular hemolysis. Especially after infections, for example, with mycoplasma or Epstein-Barr virus, there seems to be an increase in the synthesis of this IgM antibody and the resultant hemolysis. Now, the investigations. There is evidence of hemolysis and a direct positive Coombs test. So, if Coombs test is positive, there is a direct relationship between this test and the evidence of hemolysis. Apart from that, examination of the peripheral blood film at room temperature can show red cell agglutinations. So, how to manage this condition? Treatment is usually through uh, avoidance of the underlying condition. For example, I have told you there is infection by mycoplasma or Epstein-Barr virus. So, treatment of this infectious organism may improve symptoms. Apart from that, another important factor is avoidance or exposure to cold. Like I have told you, that this is a cold antibody which thrives or affects in temperatures lower than 37. So certain this person should avoid exposing himself to cold. So this is one way of managing certain patients which have cold and antibody immune hemolytic anemias. So that was all about your acquired hemolytic anemias. Now, class, we will talk about non-immune hemolytic anemias. Now, the interesting about point about this non-immune hemolytic anemias is that this acquired hemolytic anemia is due to some non-immune cause. Autoimmune hemolytic anemias makes perfect sense as the antigens have been tagged by the autoantibodies itself. So, what will be the cause of non-immune hemolytic anemias? So, the most important of that is the paroxysmal nocturnal hemoglobinuria. So, we will now talk about this paroxysmal nocturnal hemoglobinuria. The most important point you have to understand, class, that there is in this type of uh, non-immune hemolytic anemia, there is an inability to produce a substance called GPI or glycosylphosphatidyl inositol or GPI for short. Now, this is actually an anchor. This GPI actually tethers several proteins to the cell membrane. As you know, in the cell membrane, there are numerous proteins performing functions. So this GPI acts as a tether and binds them together. Deficiency of two of these proteins, one is CD59 and CD55, renders the red cell sensitive to the hemolytic action of the complements. So the manifestations will be this disease will be abnormalities in the hemopoietic functions, leading to intravascular hemolysis, venous thrombosis, or even bone marrow aplasia in severe cases. Hemoglobinuria also manifests and typically shows a dark urine at night when you go to the washroom. There will be a dark urine, and in the morning on walking. So, class, this paroxysmal nocturnal hemoglobinuria should be considered in any patient with a chronic or episodic hemolysis. Again, diagnosis is by checking the deficiency of this GPI anchored proteins by a process called the flow cytometry. Treatment of this case is usually supportive, and by supportive I mean blood transfusions are the main way of setting for this hemolytic anemia. Apart from that, another important compound which can be given in this patient is tulizumab. Tulizumab is actually a monoclonal antibody that binds to the C5 component of the complements and prevents its activation and reduces the hemolysis. If Apart from that, bone marrow transplants have also been seen to show some success in selective type of patients. So this was about your class main type of non-immune type of hemolytic anemias. Though not relatively rare condition, it can have serious consequences. Finally, class, before ending our topic of anemia, this is all about your anemia. In our previous lectures, we have discussed in great detail about anemia and its types. Finally, I would like to tell you about another small type of anemia which is associated with these types, or a non-immune type of hemolytic anemia is a mechanical type of hemolytic anemia. For example, red cells being injured due to some physical trauma. For example, due to uh, prosthetic heart valve damage, some microangiopathic